Yes, sir.
Yeah, okay, thank you. So thank you, Dr. Jali, for those kind words. I'd like to thank you and Dr. Ishwar and Dr. Subhajyoti Ghosh for chairing the sessions. I'd also like to thank my good friend, Dr. Banshi Sabu, and the whole team from Diabetes India. I've been hearing so much about this meeting. Hats off to all of you all. I don't think any of us can do or match what you're doing. I've been silently observing all the great talks. I've been listening to some of them as well. So a big thank you and congratulations to all of you. I have no conflict of interest to declare. The funding comes from Indian government as well as from the British government. Now, I am going to straight away plunge into the topic. And precision diabetes, I'm very much involved in this because we have a Department of Precision Diabetes at our center, and also because I'm part of the Precision Diabetes Medicine and Diabetes Initiative of the American Diabetic Association, and I represent India in that. In fact, we recently had a conference just on precision diabetes in April. I was part of the organizing committee actually for that conference. We had a huge attendance and it went very well. Of course, I can't present all of that here, but I'm just going to give you briefly something which relates to work done in India and from our own center. So I'll talk a little bit about type 2 diabetes, because I think clustering of diabetes, which yesterday Dr. Anjana spoke about, and therefore I'll go very fast regarding that. I didn't realize that there was an overlap when I gave my topic to Banshi at the beginning of this meeting when he asked for the topic. So I'll quickly go through that and then spend a little bit more time on monogenic diabetes and neonatal diabetes. So the clustering of diabetes, in case some of you missed yesterday Dr. Anjana's talk, all started with this very eminent group from Scandinavia, Leaf Group, and Emma Alquist, who described adults onset diabetes and had different clusters of that. And we just heard some of those from Dr. Alok Kanango's talk as well, where he talked about LADA and so on. So what they did in Scandinavia was they looked at 6 clinical variables, GAD, and GAD was discussed quite a bit in the previous talk: age at diagnosis, BMI, HbA1c, and then 2 measures of either insulin secretion, HOMA beta, or insulin resistance, HOMA IR. So using this in Scandinavia, they looked at 2 or 3 cohorts: the Scania cohort and the Scania Diabetes Registry, the Uppsala Registry, the Vasa Registry. And based on this, they came up with these 5 clusters of diabetes. The first one they called as severe autoimmune diabetes. And to me, this is nothing but LADA, which Dr. Kanango talked about, because you have GAD antibody positivity, low BMI, insulin deficiency, early onset diabetes, lean people, and that's exactly what he talked about. So that's SAID. And to me, it's only a form frust of type 1 diabetes. Not really type 1 diabetes, but belongs more to type 1 diabetes, because they can even develop ketosis and so on at some time. So the other 4 types, which Leaf Group and colleagues described, are the real subtypes of type 2 diabetes. And the first one is it's severe insulin deficient variety, where we know that deficiency and insulin resistance are the 2 main facets of type 2 diabetes. But in this one, the SID, the insulin deficiency predominates. They don't have much of insulin resistance. The opposite is SIRD, where the insulin resistance predominates, but there's not much of insulin deficiency. And then they had a mild obesity-related diabetes, where there's no insulin resistance at all, a kind of peculiar group, which we are not able to see this in India. I'll come back to that. And finally, the MARD group, or the mild age-related diabetes. This is an old age-related kind of diabetes. So when they describe these 5 types, there's a lot of interest all over the world, and people wanted to replicate it and see whether in every population they're able to replicate. And to be honest, in some of the white Caucasian populations, it has been replicated, but it's not been replicated in all populations. We were also very interested to replicate this, not because of Me Too research, or they did it, we also have to do it. It's not that way, but because we always believed that South Asians and Indians, the type 2 diabetes is completely different. The age at onset is different, our BMI is different, our waist circumference is different, our insulin secretion is different, our progression is different, everything is different. So we said we also have to eliminate, we also have to try to replicate this. But when we want to replicate it, the first thing we did was, we are not interested in the SAID variety, because that is a LADA, it's a different type, and we see that quite often in our practice, but that we really don't classify really under type 2 diabetes, and quite rightly so. Dr. Kanango also said the same thing. So we wanted to apply this to the South Asian population. The reasons why we want to do it is given here. 13 different characteristics of South Asian diabetes, at least about 200 papers that have been published on this. And there's no doubt at all. I don't think anyone in this audience will doubt that we have lower age at onset, lower threshold for BMI, higher insulin levels, insulin resistance. This is my work in 1985 in England, where we showed for the first time that if you take insulin level itself, we can distinguish the Indians and the Europeans. More recently, this has been our work where we showed rapid decline in beta cell function. We seem to be losing beta cell function very rapidly. Both cross-sectional and longitudinal studies have shown that. But to me, the most characteristic, you ask me of all of this, what is the most characteristic? It's number 5, the low HDL. I have worked in different parts of the world, and I've never seen such low HDL levels in any other ethnic group. And therefore, when we wanted to replicate it, the Scandinavian results, we somehow felt that this should be included. The low HDL and the high triglycerides should be included. Of course, there are other things like low adiponectin, high CRP, and so on, which I won't go into now. So this is a collaborative study by the University of Dundee and our center has been going on now for 5 years. It's called as INSPIRED, or the India-Scotland Partnership for Precision Medicine in Diabetes. And this is just one small part of a very big project. And it's funded by the National Institute of Health Research, NIHR, in the UK. Now let's see what happens. First, what we did was we took the exact characteristics, the same. We didn't change anything. Same criteria what they laid down, and then compared what they did in Scandinavia with our population in India. And we found that for them, it was perfect. There is no doubt. So I cannot but appreciate them and say that what they have found out is 100% okay as far as, but you can see that they've left the SAID out here because I believe that's a different group. And they themselves keep saying in the paper that SAID is different. But if you look at SID, SIRD, MOD, and MARD, everything fits in properly. What do we expect in SID? They have the lowest insulin secretion, HOMA beta, okay? That comes out exactly as one would expect. What would you expect in SIRD? The highest HOMA beta, exactly so. So everything fits in. If you look at HOMA IR, highest in the SIRD variety, and so on and so forth. Look at the age of diagnosis in the MARD variety, 67 years, plus minus 8.5. Our lifespan itself is only 67 years for males. And for females, it is 69 years, and those without diabetes. And so with diabetes is much shorter if you take the mean, okay? So their whole profile fits in very well with the Western population. We try to do the same thing. Let's not try to invent anything. We'll do the same thing and see whether Scandinavia clusters fit in here. It was all over the place. We just could not fit in. Wherever they had some, look at the MARD in our group. The MARD, the mild age-related one is 50 years. Okay, 50 years old age for us as far as diabetes is concerned. Look at the mean age here, 41, 44, 48. Look at here, 56, 65, 48, 67. Completely different, about 15, 20 years older they are. Look at the mean BMIs. They have 33, 35, 27. Look at us, 24, 25, and so on. Much, much lower than what they had, okay? And if you look at HOMA beta, HOMA IR, all completely different. I'm not going to full detail because number one, Anjana presented. Number two, it's all there in the paper if you want to read. Very detailed explanation as to why we could not replicate it. And all the results are actually given in the supplemental tables and so on. So then we said, let's try to replicate it in another way. Why should we take only the clusters which they said? First of all, they didn't include HDL and triglycerides, which we felt is the most important in our population. So we said, let's do it all over again. After failing to replicate it, let's do it all over again. Where did we get our patients from? In the initial analysis, we took patients from all our centers from across the country. As you know, we have over 500,000 patients in our electronic records. We selected around 20,000. Remember, they had only about 8,000. So we had about 2.5 times that number. So 19,000 to be exact, with the same, otherwise the same criteria, but from across India to make it as representative as possible. However, I must say that this is from our own private clinics, and therefore it may not be totally representative of the population, but that's where we have to start. We had all the data in our electronic record, so we went ahead and we did it. Now, when we did it, we took most of these, which they had used, age, BMI, waist, but now we added HDL and triglycerides because we said this is the most characteristic one and we should do it. And I'll tell you why we were right. Then we also added, we said the HOMA beta and HOMA IR are research tools. Nobody does that. C-peptide, which Dr. Alok Kanango mentioned in his talk, both fasting and stimulated, it's a kind of routine test for us. We do it in almost everyone. So we had this data and thousands and tens and hundreds of thousands of people, we have this data. So using this, we were able to do the clustering. Now, what did we find? We found that the first variety, the SID variety, was quite similar to what they described in Scandinavia. The severe insulin deficient. They're thin, they are insulin deficient, and they don't have much of insulin resistance. The other variety, the MARD variety, was also similar, except that the MARD that they describe is 67 years, our MARD is 50 years. So there again, there's a big difference. But the two new ones, which we were very, very impressed with, was this one, the insulin resistant obese diabetic, and the combined insulin resistant and deficient diabetes. Now, this particular variety, the third variety, had not been described from Scandinavia, and it seems to be unique to our population. Why? Because first of all, they have both insulin deficiency and resistance, and I showed you about the the rapid decline in beta cell function, on which you have several publications. And they also had the lowest HDL and the highest triglyceride. I told you that this seems to be the feature of Asian Indians and South Asians. And these people had the lowest HDL and the highest triglyceride. So they were the most characteristic group of the Asian Indians, or the most typical. Now, if you see, using those criteria, we have now reclassified our patients to see whether these four characteristics, the four subtypes that we described, are correct. Now you can see the age at diagnosis is 50 in the MARD. So that is same whether you use that criteria or this criteria. But now all these are coming out okay. See, the lowest C-peptide is in the SID variety, which has the highest C-peptide, IROD variety, which has the highest HOMA beta, the IROD variety, which has the highest insulin resistance, IROD variety. Okay, so now look at the triglyceride and the HDL, which I want to tell you about. Look at our HDL, all low in all the four groups. But look at the third variety, they have the lowest among the low of the HDL. And if you take the triglyceride, this is actually high. For a mean, it is actually high. But look at the triglyceride in the third group, 351, more than double of the other groups. So this is a group which is standing out from the other groups and unique to our population. That's why it was a lot of excitement when this was published, and a lot of people have been quoting this in various conferences and so on. Now comes the next question. Okay, this is all fine, but this is coming from one clinic of Dr. Mohan's, and how is it representative of India? Very valid point. So before we published, what we did was we went back to INDIAB. INDIAB, as you know, is representative of India. Nobody can question that. It's the most representative study ever done. This is in all the states in India, urban, rural, proper government stratification, and very well done study, as you know this. So from this, we took newly diagnosed patients from all over the country, and then we use the same variables. Now what we did was, to make it even simpler for people like you who may not be doing C-peptide regularly, we removed C-peptide. We kept the other 6 and we removed both the C-peptide and said, let's see with this, if we are able to replicate it, then our findings are solid. And I'm happy to say that in the same paper, we again showed it. Again, now just look at, I don't want to bore you with all this, but if we just look at the HDL, again lowest, and this is from INDIAB. This is not from our clinics at all. This is completely from Indian sample, urban, rural, representative sample. Because again, you can see the lowest HDL is in the third variety. The highest triglyceride is in the third variety. Again, more than double. Just like there also we are 350, 360. Here it's coming to 400 actually. So the same replication, thank God, we are able to get. And therefore, we now know that these 4 clusters are stable. I'm not going to go into it, but with collaborators, including Dr. Banshi Sabu and many others in India now, we've got fresh samples now from the clinics representative of different parts of the country. And I'm happy to say that we're just writing up another paper on this. We're trying to look at drug responses, whether they are different in these 4 groups. And we got exactly the same cluster when we did a completely different subset from India. So now 3 times it has been replicated. So there's no doubt that these clusters are absolutely true, and they are novel, and they're being described for the first time. This is actually the basis of precision medicine, because otherwise we'll treat every type 2 diabetic the same. Now we're able to say this different type has to be treated. Now we are doing an RCT to see whether which drug should be used in this, and I'm not going to go into the details of that. But what's the clinical relevance of this clustering? Why should you do all this? Why don't you just give them all metformin and be done with it? Because the response varies from group to group. Also, the complications varies from group to group. For example, the SID variety, the lean variety, the insulin deficient variety is supposed to develop more of neuropathy and retinopathy, but not more of nephropathy. And that is what Scandinavian group showed. We were also able to show the same thing. You see the hazards ratio for retinopathy, it is very high in the SID group. But we had one more surprise. The third variety, remember, they also have insulin deficiency. So they are also more prone to retinopathy. That was not known earlier. Now, as far as kidney disease is concerned, the obese ones, insulin resistant ones, are more prone to NAFLD, to kidney disease and to heart disease. We were able to confirm that. You can see the insulin resistant variety is more prone to CKD. But again, we had a surprise that this, remember this group, the CARDD also has insulin resistance. So they are also more prone to nephropathy. If anything, they are more prone to nephropathy because they have additionally insulin secretory defect as well. So this is a major finding that we had. The next point that we wanted to see in precision medicine was how do they respond to treatment? Now, as one would expect, the SID variety shown here in blue will be the one most difficult to treat and to get to the target of 7%, below 7% A1C. So there's only about 20-30% we're able to get under target because we're all treating them in the same way, not in a precision medicine way. Remember, it's a retrospective study. So they were the most difficult to get under control. Which was the easiest? The MARD variety, because they are the older one, they're milder diabetes, they easily got under control. Which was the next most difficult after the SID variety? Not surprisingly, the SERD variety, because they also have insulin secretory defect. So these two groups are more difficult to treat. These groups are easier to treat. Now this explains, in your practice, you'll find some patients responding beautifully, some patients not responding beautifully. Now we have an explanation as to why some people respond and why some people don't respond. And that, of course, was published in British Open Diabetes. Now switching tracks, now let me move on to other forms of diabetes where precision diabetes is practiced. And this is where classical precision diabetes is practiced. And MODY, or maturity onset diabetes of the young, is one of the most classical. You all know that this is described, MODY was described by Tatchell and Fans in 1975. They have young age at onset, but they don't have ketosis. They are controllable without insulin for at least 5 years, so it's not LADA. Impaired insulin secretion is the main point. They don't have insulin resistance, so they're not type 2 diabetes, and they have autosomal dominant inheritance, goes through several generations. Of course, different types of MODY have been described, and over the years we've been publishing so many papers on MODY 1, MODY 2, MODY 3, MODY 5. We've been publishing, including some newer MODYs which we have described from India. But more recently, we know that, you know, MODY 4, MODY 6, MODY 7, MODY 9, these are not really MODY at all. And there is a lot of controversy regarding this. So we actually stopped reporting on these MODYs, and we only now report on the major forms of MODY. We've completely rewritten our protocol for diagnosing MODY, because even from CMC Velo, there's a lot of confusion. They said MODY 4 is the commonest form of MODY in India, and that's not even it's a non-existent MODY as far as the world is concerned. But why bother about MODY as a clinician? Why should you bother about it? That's because we get children like this. This is a 16-year-old girl, and there was some discussion about this in the previous talk as well. She's thin, presented severe diabetes, HbA1c is 10.4, and therefore people said this is type 1 diabetes. Let's treat her with insulin 3 times a day. So the parents brought her and said, can you relook at this and see whether she's really insulin dependent or not? Now, when they come to us, what we do, the first thing we do before we do any of these tests is to take a pencil and a paper and draw the family history, which is what we did. So when you drew the family history, this is the girl, the proband, 16-year-old. At that time, her sister was not diabetic, but her mother had diabetes, and you can see her grandmother had diabetes, and her great-grandfather and grandmother had diabetes. So this 4-generation transmission, autosomal dominant, is very striking. You don't see this in type 1 diabetes. Next step we did was to do a C-peptide assay, which showed a good insulin reserve, not like type 1. Then we did GAD antibodies, came positive. We did zinc transporter. By the way, we don't do much of IA2. It didn't work very well in our, I heard a lot of things about IA2 in the previous one. We have done IA2, but it doesn't work very well in our population. And I heard the same thing from All India Institute, Dr. Nikhil Tandon also. So these are our standard ones, which we do. GAD and zinc transporter, we do for everyone suspected to have type 1 diabetes. Both were negative. So when both were negative and C-peptide is good, we said this may not be type 1 at all. Maybe it is MODY. So we did the MODY genetic testing. And many years ago, actually, 2009, we described this family. It's a novel MODY mutation, the HNF1 alpha, arginine 263 histidine mutation in this family. First one we detected was this proband. By that time, it took about 6 months to 1 year to get it done. Now we can get the results in 3 weeks' time. Those days, it used to take 3 to 6 months. By the time her sister came, she had developed diabetes. So we quickly did the genetic test for her. She's also MODY. Mother had MODY. Uncles had MODY, aunts had MODY, aunts' children were this girl's age, they also had MODY, and of course, some of them had died, so we couldn't get the samples. So everybody in the mother's side who had diabetes had MODY 3. So we knew this girl has developed it from the mother, she has MODY 3, and guess what? MODY3 responds to sulfonylureas. So what did we do? We took her off insulin, started her on sulfonylurea. The one which been studied most is glibenclamide. And our own studies, now we are doing trials on glycoside as well in MODY. But that time we put her on glibenclamide. We stopped the insulin completely. She showed beautiful response, and the HbA1c came down to 6%. Now it's about, I think, almost 15 years, 14 years or so since she and her sister came to us, and they're still coming to us, and they're still responding to glibenclamide. They still have not gone to insulin. Imagine if this. So MODY genetic testing helped to avoid unnecessary lifelong insulin therapy. If we had not done this, she would have been still taking 4 times insulin per day. They'd have been still saying she has type 1 diabetes. This is a classical example of precision diabetes. And that's why we have to go the full hog and see what type of diabetes our patients have. It's worth all the effort. Now, there are many, many papers we published on MODY3, on MODY1, on MODY2, on MODY5. We have described new forms of MODY, and I'm not going to go into all that. But the last one I want to talk about today before I close is neonatal diabetes. If you thought MODY was very interesting, wait till you hear about neonatal diabetes. This is much more dramatic because this occurs below 6 months of age. So imagine a newborn child, 1 month old, having diabetes. Now, what do you think? Type 1 diabetes, start insulin. Think again. Type 1 diabetes below 6 months of age is very, very unusual. Very, very unusual. It's most likely to be neonatal diabetes. And if you have neonatal diabetes, you don't need insulin. You can treat with tablets. So neonatal diabetes of 2 types, the transient variety, which goes away after the first 6 months, before the first birthday, and the permanent one, which stays permanently. Now in India, we have got hundreds of cases. Only 2 had transient neonatal diabetes. All of them have permanent. Maybe with the transient one, don't get referred to us. Maybe it's that. But in Europe, the transient one is more common than the permanent one. Let me again tell you a story. This is a 72-year-old lady, a girl, a female baby who was referred to us from Kolkata. And they said, can you rule out, because it's 3 months old, can you see whether this child has neonatal diabetes? So she had been started on insulin injection. She was on 14 units, 3.5 units per kg body weight, given us 4 injections per day. But her blood sugar remained 300, 400. So she was referred to us and said, can you evaluate her? So what we did was we straight away took her up for genetic testing. What we found was a heterozygous mutation in the KCNJ11 gene. Now, this is a classical form of neonatal diabetes, of permanent neonatal diabetes in exon 1, which responds to sulfonylureas. So we said, okay, now let's stop the insulin and start sulfonylureas. So we started on glibenclamide, and this is what happened. You can see, this is the red is the insulin dose. You can see the insulin dose coming down, 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 and the insulin becomes 0. Okay. Now, this is the green is the sulfonylurea dose. We started there and slowly built up the sulfonylurea. And the blue is the blood glucose values. When she was on insulin, you can see the blood glucose levels very high. But after the insulin stopped and the sulfonylurea is increased, you can see the blood glucose levels coming down. It's all below 100 now. Okay. So 100, 120, 130. Completely normal with very small doses of glibenclamide. So we were able to completely change this child. This girl has also now finished several years now. She's still on glibenclamide. So she's not come to us. She would have still been on insulin. Sugars have probably been 400, 500 because she's not responding to the insulin as well because the exact defect was not being treated. By day 5, she was able to stop her insulin and the sugars were completely normal. And this is a big series, the first series. We've written up 3 or 4 papers after that. We're also doing a lot of work on congenital hypoglycemia, by the way, very large series we have. I'll show you that in a minute. So this is how these children respond. If they have either an ABCC8 mutation or a KCNJ11 mutation, before sulfonylurea treatment, that's the A1C, 14, 16, 10, 11. After sulfonylurea, you can see it's 7, 5.9, 6, 7.4, complete response. Similarly, the fasting blood sugar also coming down. This is our registry in the neonatal diabetes registry. We have 265 cases of neonatal diabetes, of which 248 are the permanent variety and the others are still unclassified. And most of them belong to the KCNJ11 ABCC8. Now, just yesterday, just today actually, we have written up a paper on the insulin gene mutations, the 3rd one and the first report from India that's being submitted for publication. We have various genetic syndromes which come to us, Walcott-Rollison syndrome and many other Didmode syndrome and the TRMA, the thiamine responsive megaloblastic anemia syndromes. From all over the country, they come to us and we're able to accurately diagnose and say which is which particular type of diabetes. I also said we have 129 cases of congenital hypoglycemia. And these also have the same mutation, but one is a gain of function mutation, one is a loss of function mutation. If they have one, they go into diabetes. If they have the other, they have hypoglycemia. We are also able to say from the genetic testing who will respond to diazoxide. You give diazoxide, the children's blood sugar will become normal. But if they are diazoxide unresponsive, you either have to give octreotide or you have to do a subtotal pancreatectomy. So they come to us as a last resort. After doing the genetic testing, we then decide who to send for pancreatectomy and who will respond to diazoxide. And we've written a very big paper, which is also now gone off for publication. And this, of course, makes big news. This is a girl, that child from Calcutta, Ivana Das is her name. And it's almost dramatic. It's almost like a miracle when that happens. So to conclude, ladies and gentlemen, I could only give you a bird's eye view. There's much more we do in precision diabetes, but I would like to submit that precision diabetes is slowly coming of age. It can be applied to all forms of diabetes. In fact, we're doing work on type 1 diabetes as well, and we'll probably present that next year in Diabetes India. With respect to type 2 diabetes, 4 clusters, and I told you about that. The SID and the MARD are the same as Scandinavia, but the IROD and the SERD are unique. Study of monogenic diabetes helped many children with neonatal diabetes and youth with MODI to go off insulin. So if any of you have it, we'll be happy to do it free of cost, by the way. This is not done for commercial purposes. So if you have any cases of either MODI, which you think is clear MODI, or neonatal diabetes, just send it to us. And 4 weeks time, we spend it from our pocket. We spend it. It costs about 3,000, 4,000 rupees for us to do it, but that's my charity. So I give that to the nation. And finally, precision diabetes can help offer precision diabetes and thus improve the quality of life of people. So with that, I would like to thank you. And if there are any questions, I would be happy to take those questions.